Hello everyone, welcome back. I hope you had a good weekend. Today we are going to cover Chapter 11, which is over our fluids and irrigation solutions. Alright, so just a little introduction. The primary goal of the surgical team is to maintain the patient's homeostasis. Blood and fluid replacement are vital to this. There are three classifications of IV fluids. Those are crystalloids, colloids, and blood products. We will go over each of these individually in a little bit. We have replacement fluids. These are ordered to replenish losses caused by hemorrhage in surgery or uncontrolled vomiting and diarrhea in the medical setting. We have maintenance fluids, which sustain normal fluid and electrolyte balance. And then we have irrigation fluids that are used to provide visualization, remove blood and debris, and add medication to the surgical site. Okay, going on to some fluid and electrolyte management. Right, first we're going to start off with a bit of a physiology review. So fluids, electrolytes, and non-electrolytes make up about 60% of our total body weight, and they're distributed in two compartments. They're either intracellular fluid, which is ICF, and extracellular fluid, which is ECF. Major electrolytes break down into these various things. Chloride, which is the most abundant anion in ECF. Sodium, which controls water distribution. Potassium controls our pH, and it's also responsible for transmission of nerve impulses. We have phosphate, which is stored in teeth and bone. We have magnesium, which is sodium potassium pump. It's part of that, and the breakdown of ATP. We have bicarbonate, sulfate, and carbonic acids, which are all part of the acid-base balance in our bodies. And if you see table 11.1 on page 147, it is a very specific and in-depth breakdown of all of these different electrolytes and their breakdowns. Okay, then we have non-electrolytes that are present in body fluid. These are glucose, urea, and creatine. Electrolytes' three main purposes in homeostasis are to control the volume of body water by osmotic pressure, maintain the acid-base balance, which is our pH, and they serve as essential minerals. Two important electrolytes in surgery, which we've talked about a bit before, are calcium, which is involved in blood clotting, neurotransmitter release, and muscle contraction and cardiac output. Normal levels of calcium are 8.9 to 10.2, and too much or too little causes cardiac arrhythmias. And too much, again, hypercalcemia, too little, hypocalcemia. And we have potassium, which we've talked about quite a bit. We know too much is hyperkalemia, too little is hypokalemia, and too much or too little can cause metabolic problems. And as we've said a few times before in the past, the normal levels of potassium are 3.5 to 5. And then we have sodium. This is the principal cation to ECF. The normal levels are 135 to 145, and too much is hypernatremia, too little is hyponatremia. An easy way to remember that is hypernatremia. If we have the HYPER, that means too much. And Na is part of that is the symbol for sodium, Na. It's an easy way to remember that. Okay, so we'll talk a little bit about IV fluids here. An IV drip is started on a patient for two purposes: direct access to the circulatory system for med administration, and for administration of parenteral fluids. Every surgical patient will have an IV. They may be used at a slow rate to keep the vein open. Parenteral fluid therapy has three objectives. That's to maintain daily fluid requirements, restore previous losses, and replace current losses. The IV fluids most commonly used are called crystalloids. They're composed mainly of water with some dissolved electrolytes, dextrose solutions, and multiple electrolyte solutions. The names of the solutions are abbreviated on the bags. The letters indicate the components of the solution, and the numbers indicate the strength or concentration of the components in the solution. So for example, D5W is a dextrose that is 5% in water. And I want you guys to pay attention to table 11.2 on page 148. That gives some good examples and breakdowns of what those are. All right, so some common IV fluids in surgery. First, we have sodium chloride, which is abbreviated NaCl, 0.9%. It is isotonic, and it is the most common agent for fluid replacement and simple hydration in surgery. It's packaged in 50, 150, 250, 500, and 1,000 milliliter bags with varying concentrations. When chloride loss is greater than or equal to the sodium loss, treatment of metabolic acidosis and to replenish lost sodium is what we're going to use this for. Okay, it's also used when transfusing blood because it does not hemolyze the blood cells, which hemolyze means to fill with fluid and rupture. And oftentimes you will see this on the preference card or hear it abbreviated in surgery as NS, which is normal saline. And normal saline is that 0.9% solution. Okay, then we have dextrose. Dextrose is used in patients who require an easy metabolized source of calories. Dextrose is a natural sugar that's found in the body, and it provides energy for cellular activity. This is also available in varying concentrations in non-sterile or normal saline or water. In water, it hydrates the surgical patient, spares the body protein, and it enhances liver function. The percent of the solution determines the use in surgery, so if it's less than 10%, it is being used for peripheral hydration, providing calories, and assessing kidney function. However, if it's more than 10%, we are looking to reverse some hypoglycemia, provide calories when less fluid is needed, and with amino acids for parenteral nutrition. All right, it's frequently used in saline or sodium chloride, I guess is what that is, for treatment of circulatory insufficiency and shock caused by hypovolemia or volemia, which is low circulating blood volume. Early treatment with plasma for a loss of fluids caused by burns. Dextrose solutions given IV increase insulin and oral hypoglycemic requirements for the diabetic patients. It is not used in conjunction with transfusion of blood products because it can cause hemolysis, which is the breakdown of blood cells. And there is an ionosol B and 5% dextrose injection that are used for the maintenance and replacement of electrolyte solutions. Next, we have lactated ringers, or LR is what you will hear it called most often. This is a physiological salt solution used to replenish the patient's electrolytes and rehydration to stimulate renal activity. This is the second most common IV fluid administered in surgery. It's also used to replace fluid lost from burns or severe diarrhea, and it really closely resembles the composition of that extracellular fluid. It should not be used in patients that cannot metabolize lactate. These patients, for instance, that will have liver disease, Addison's disease. There's a good insight, 8.4 from Chapter 8 that goes over what that is. Severe pH imbalances, shock, or cardiac failure. There is a solution, Hartmann solution, that can be substituted for LR if any of those things are present. Okay, then we have Plasma-Lyte and Iso-Lyte. These are electrolyte balanced solutions that are compatible with the pH of blood. They're used to treat massive amounts of fluid lost with uncontrolled vomiting and diarrhea, and the composition of this is similar to the plasma portion of the blood. Okay, we also have normal sol R. This is an isotonic solution with electrolytes and water. It's used for parenteral replacement of acute losses of that extracellular fluid. This does not disturb the normal electrolyte relationships. It can be used as an adjunct to increase circulatory volume in patients that have a moderate amount of blood loss. It does not cause hemolysis, so it can be used with a blood infusion set. And there is a table that I'd like you to take note of, 11.3 on page 150. This has a complete IV fluid list and its comparisons. It's a great table to take note of. Okay, going through just a little bit of the IV equipment and supplies. First, we're going to have the flexible catheter that's inserted via needle into our patient's vein. The needle will be removed and that flexible catheter is left behind and taped in place. And it'll be there throughout their procedure then and some of their PACU. The primary IV tubing connects to the hub of the catheter and the other end is connected to the container of IV solution, so their bag. The tubing is going to consist of a drip chamber, injection port, and a roller clamp. You might also see some secondary IV tubing used when we're giving medications. This is called a piggyback. This tubing is shorter and it is usually hung higher than the primary tubing so that it will infuse first. And it's usually used with antibiotics. So here we have a picture of our basic IV setup. Excuse me. Down here we have our catheter, flexible, that's been taped in. This is just a clamp to kind of cut off fluid if we need to for changing out the hub or whatever maybe you need to do. We have extension tubings that can connect together with lure locks to make our IV longer if we need. But this is going to be our primary tubing here. Right here is our roller clamp. This regulates the rate of infusion so we can stop or go or slow it or speed it up if we need to. This right here is our drip chamber. So this is where our tubing is spiked into our primary IV bag, and this is where you're going to see that fluid dripping and what kind of rate it is, slow, fast, or maybe not at all if the tubing is kinked. We as surgical techs have a direct eye on this while we're working, so it's easy to kind of keep an eye every once in a while and look and see and let our anesthesia know, hey, it doesn't look like their IV's running. And here, this one is our secondary tubing. You can see how much shorter it is. We do hang it a little bit higher than our IV primary. Gravity will take over and that will run in first. And this is usually going to have any kind of antibiotics that they might be getting either during surgery or prophylactically. All right, so we'll talk about some blood replacement here. And a little bit of physiology review to start off. So as we know, blood is a fluid connective tissue. It transports oxygen, nutrients, wastes, hormones, and enzymes throughout the body. It does maintain our acid-base balance, temperature, and water content, as well as carrying the body's immune response. So our blood's doing a lot. Blood volume varies with patient body size, the amount of adipose tissue, and changes in fluid and electrolyte concentrations. However, in the average adult, the circulating blood volume is about 70 milliliters per kilogram of body mass. Okay, blood consists of two main elements. We have our formed elements, which make up about 45%. Those are our red blood cells, which make up 99% of the formed elements. And they contain hemoglobin, which transports our oxygen and is often abbreviated as HGB. Then we have our white blood cells, which provide protection against foreign microbes. Platelets mediate the clotting process, and plasma is our fluid component of our blood. Normal hemoglobin is 12 to 16 grams per milliliter in adult females and 14 to 18 grams per ml in males. Okay, hematocrit is the volume of red blood cells in a given volume of blood. It's expressed as a percentage, and normal range is 35 to 52%, and that depends a bit on age and gender. But there is another table, 11.4 on page 151, that is a good example, and it gives a good list of blood values. That's an excellent resource for you guys. Okay, in cases of known blood loss, the patient is typed and cross-matched for donor blood. The blood type is determined by antigens that are on the surface of our red blood cells. Antibodies are also present in plasma, and I want you guys to reference table 11.6 on page 152 for that. Blood cross-match is performed to determine compatibility between donor and recipient blood. And RhoD or RhoGAM is a medication that can be used to treat possible blood compatibility reactions. It's an injectable blood product that's manufactured from human plasma, and it contains anti-D to suppress the immune system response from Rh negative mothers to the Rh positive fetus. This is only available for IM injection. In Insight 8.2 on page 105, we'll go over that as well. All right, so some indications for blood replacement. The first fully recorded blood transfusion occurred in France in 1667. It was done on a 15-year-old male. He was given lamb's blood, and it was successful, probably because it was a very small amount. However, by 1670, they were noticing some reactions occurring with blood transfusions, so it was banned. Then in the early 19th century, Dr. James Blundell performed some, had some successes. He developed some instruments for the process, and he published his results. About half of them were successful. In 1901, Carl Landsteiner discovers that all human blood is not alike, and now it is known that blood must be compatible in both type and Rh factor. If unmatched blood is given, agglutination occurs, which is a big fancy word for blood clumping. Agglutination. Okay, the most common indication for blood replacement in surgery is going to be hypovolemia, which is a low circulating blood volume. And it's most frequently going to occur in trauma or vascular procedures. Okay, hemorrhagic, or otherwise known as circulatory shock, occurs when a patient loses a certain amount of blood. It results in decreased oxygen supplied to the vital organs. We'll see an increased heart rate and decreased cardiac output. Okay, other indications can include the restoration of oxygen carrying capacity and to maintain some clotting properties. If trauma and patient blood type is unknown, O negative can be administered, but the surgeon must document the need for blood release without compatibility testing. It's very carefully documented. All right, let's go through some options that we have available for blood replacement. The first one we're going to talk about is the homologous donation. This is donor blood, or otherwise known as allogenic blood. So this is the blood that we are getting from the blood bank that has been donated by other people. The blood bank is responsible for collecting, processing, and releasing all donor blood. Okay, all donor blood is tested for signs of syphilis, hepatitis, or exposure to HIV, but it needs to be noted that it is still possible for donor blood to present some risk for transborn or the transmission of bloodborne pathogens. Okay. Blood is separated during processing into components and administered to treat specific needs. 1 unit of donor blood separated into components can actually treat several different patients. And this is generally what it's going to look like when it comes to the OR. It will come in a bag. This is going to be usually a patient sticker attached to it with the patient's barcode and information. All of these different barcodes have been scanned for verification. But we can see this is type O, and it is Rh negative. Okay. Okay, then we have whole blood. This indicates the blood composition has not been broken down or altered. It consists of our red blood cells, plasma, stable clotting factors, and anticoagulants. It's rarely used for transmission today, only in cases of acute massive blood loss. Packed red blood cells, the use of these is with synthetic volume expander. It's proven to be as effective as whole blood without the risk of blood transmission reactions. It's obtained by removing approximately 200 milliliters of plasma and most of the platelets from 1 unit of blood, which is about 500 mLs. This does help restore oxygen carrying capacity of the patient's own blood, but typing and cross-matching are still required. And this is what that would look like if it came back to us. And you can see here it just says red blood cells, and this is a B positive type. And we can see here that it was a volunteer donor that gave it. Okay, then we have plasma. This is administered when clotting factors are needed, as well as circulating volume. This need is frequently seen when several units of blood have been replaced because the clotting factors have been removed from donor blood. It's usually stored as FFP, which from our previous chapter is fresh frozen plasma. That's to preserve the clotting factors, and it's usually just thawed in a water bath before administration, and this is type specific as well. Okay, then we have our platelets. These are administered when large amounts of donor blood have been used. They're a result of massive transfusions, maybe the inability to clot properly. They may be administered prophylactically in patients with low platelet counts, but they must be continually agitated during the surgery and during administration to prevent clumping. Okay, there is no blood type needed, and plasma or protein-rich plasma can also be obtained for wound healing. We do that quite a bit, PRP, especially in orthopedics. There is an insight on page 154 that I'd like you to read and take note of that goes over that. And here are a couple examples of what those would look like. So over here on the side, I know it's kind of a blurry picture, but this is what our platelets would look like. So as you can see, they're kind of a jelly-ish substance. So we're just going to keep squeezing and agitating this bag to make sure that they don't clump. And this is what our FFP is going to look like when it comes to us from the lab. So what we would do, as it said, is just get a basin with some warm water, and we would put this in a warm water bath to thaw it out before administration. Okay, then we have cryoprecipitate. This is a plasma component that's used in the treatment of bleeding due to hemophilia A, von Willebrand disease, disseminated intravascular coagulation, and the lack of factor VIII. And this is usually given in 4 to 6 unit pools at a time. So this is given rapidly and in large volume. Autologous donation is a patient's donation of their own blood. It can be done up to 4 days prior to the procedure, but 1 month is usually preferred. Okay, next we have volume expanders. These are our crystalloids, which are solutions that contain salt or sugars. They include normal saline, lactated ringer, and hypertonic saline, which means more salt. And then we have our colloids. These are solutions that contain proteins and other large molecules. They're osmotically active, and they draw fluid from the extracellular fluid compartments into the blood plasma. Some examples of this are albumin and dextran. Okay, we have heat-of-starch, which is a synthetic used for osmotic properties. There's no oxygen carrying capacity, but it's needed for red blood cells, which do. Okay, it's made from cornstarch, contains electrolytes and acts as albumin in managing shock. And when given IV, it expands the blood volume by about 1 to 2 times the amount that's infused. So it does a good job of that. Then we have growth factors. These are hematopoietic growth factors. They're hormone-like substances that encourage the bone marrow to produce more blood cells. They're only used in the medical setting at this time because it takes about a couple of weeks, actually, anywhere from several days to a few weeks to raise those blood counts. So we're really only using that in the medical setting. Okay, another process that we use in surgery quite often is autotransfusion. This is collecting, processing, and reinfusing of the patient's own blood during surgery using a unit we call the cell saver. Okay, blood is collected in a suction device, and it's aspirated into the machine where it's processed and then reinfused. Another option that we can do with the cell saver is when the canister is filled, it can be taken to the blood bank where it's processed and then it's brought back to surgery for reinfusion. Okay, this cannot be used in the presence of infection, cancer cells, amniotic fluid, or collagen hemostatics and antibiotics. Those can get sucked into the machine and cause clotting. So if those things are present, we do not want to use them. And then cancer and infectious cells, obviously, we do not want to put back into the body. And here's an example of what that cell saver would look like. As you can see, we have suction coming here from the patient going into this canister here, and it's being fed into the machine. Waste products are being put, and then waste products are being disposed of, and proper blood is going back in, circulated back up to these infusion bags where they can be put back into the patient. Okay, then we have oxygen therapeutics. These are agents that enhance the oxygen carrying capacity of the blood, and they're divided into two categories, perfluorocarbon emulsions and hemoglobin-based oxygen carrying solutions, or HGBOC. No products of these have been approved by the FDA yet, but several are in varying phases of development or clinical trials. And those are HemoPure, Polyheme, and HemoSpan. And there is a little write-up on each of those in your book that I'd like you to go through, but we won't go through them here. All right, so the procedure for donor blood replacement and surgery, the way that's going to go is once our surgeon realizes the need for blood, the request for blood is sent via the computer or a requisition form to the blood bank. It's going to include the type of blood product that's needed and all of the patient info along with a barcoded label that is linked specifically to that patient. So that will have the patient's blood type, their birth date, all of their identification factors. The patient blood is typed and crossed and matched, and the patient is identified with a special wristband. A sample tube of the patient's blood is sent to the lab so that they can get that type and cross. Okay, once somebody goes back to the lab to get the blood, confirmation of the requisition is sent back to surgery along with each unit of the released blood. Once it's back to surgery, if it's being used right away, it will be kept into the OR. If not, it's going to go into the refrigerator. It's a specified blood refrigerator. It's kept at 1 to 6 degrees Celsius. Plasma is stored frozen until time of need, and platelets are stored at room temperature. Okay, blood should be transfused warm, so we have things called blood warmers that are available and used for those, as well as some built-in filtering devices. Right, here we're going to go over some of our irrigation solutions. We are almost through this chapter. So our basic irrigation solutions, the most common, as we said, is going to be our normal saline, which is 0.9% concentration. This is the irrigation of choice in open and endoscopic procedures. This is isotonic, sterile, topical. It's electrolyte containing solution. What I do want you to note though is that non-sterile or normal saline is conductive. That means it should not ever be used in the presence of the electrical surgical unit. Okay. The danger comes from the transfer of heat to current, or the heat and current to adjacent tissues. When used in open surgical procedures, most fluid is suctioned from the field, so saline can be used with a little bit of risk, very little risk. However, in endoscopic procedures, the electrosurgical unit is applied within the fluid confined space, so other irrigation solutions that don't have conductive properties need to be used. Okay, so we want to try and not use normal saline with the ESU. Okay, some of the uses that we are going to use, or that are included, brain mash. We are going to use these to rinse indwelling urinary catheters. We can use them to rinse out surgical drainage tubes, wash or rinse tissues, soak surgical dressings. It can serve as a diluent or a vehicle for delivering other pharmaceutics as well, such as our antibiotic irrigations. Okay, Okay, excessive volume of the solution or pressure during irrigation can result in distension or tissue disruption. So we just want to be mindful of how much and how fast we're delivering it. We also use sterile water. This is used to rinse instruments, cool them off after autoclaving, remove residual disinfectant before we touch the patient's skin. It can be used to cool the saw blades or burrs. Oftentimes, if we're working on very hard bone, those can get hot when used. Remove the powder from our surgical gloves before we make incision. Most places have gone to powder free, but there are still a few that have powder, and that's not necessarily the best thing for the surgical wound, so we'd rinse them off. It can be used to clean our surgical gloves throughout the procedure. Also to dilute prep solutions such as Hibiclens or betadine, and to fill the balloons on the Foley catheters. So lots of uses for sterile water. Sterile water is non-conductive, so it's safe to use with electric surgical units. It's oftentimes used in a TURP, which is a transurethral prostate resection. It's often used with that as it's not absorbed through the bladder. So I want you guys to take note of Insight 11.4 on page 158. That goes through TURPs. However, it is contraindicated with cell saver, cardiovascular procedures, and in the presence of cancerous cells. And there is a caution on page 158 that will go through that with you in detail. And then we have PhysioSol. This is a balanced electrolyte solution used as a sterile irrigation for wounds and for washing and rinsing purposes. It can be used on body joints as well because it does resemble synovial fluid, such as in our knee. Okay, moving on to sorbitol, 3%. This is a urologic irrigation. It's non-conductive, it's non-hemolytic, and it is also a non-electrolytic. It has a high degree of visibility without conducting heat and current from the ESU to tissues. So we use that a lot in urology. We also have glycine, 1.5%. This is also a sterile, non-conducting, non-hemolytic fluid. It's used to irrigate body cavities. It's oftentimes used in a TURP or a hysteroscopy as well. And then we have Hyscon. This is a 32% solution of dextran 70 suspended in glucose. And this is used to distend the uterus during a hysteroscopy. We have some synovial fluid replacement that we can use. It goes by ViscoSeal. It's a 5% or 0.5% concentration of isotonic solution of hyaluronan of fermentative origin. That is a fancy way of saying it's used to irrigate joints during arthroscopic procedures and as a synovial fluid substitute because it closely resembles that hyaline cartilage in our joints. It will displace leftover irrigation fluids, and it does reestablish some normal protective hyaluronan coating in those joints. And finally, at the end of this chapter, we have some irrigation equipment and supplies. We have the asepto, which is the most commonly used irrigation device for open procedures. It does hold about 120 milliliters. A lot of times you will hear people call it the turkey baster. It's what it looks like. We have the bulb syringe, which is designed to irrigate smaller areas and to aspirate the nose and mouth of infants. It's that small blue pliable one. And then there's a couple of evacuators that we use to insert and remove irrigation in closed areas, mainly the bladder. And the two examples that I want you to be familiar with are the Ellick and the Toomey syringe. And we'll have some pictures of these on the next slide. And then we have continuous irrigation. These are closed disposable irrigation systems with tubing that may be straight or Y-shaped, depending on how much we are using. Cystoscopy, hysteroscopy, arthroscopy. Some of our older school guys will use these. They may be hooked to suction as well, i.e. an example of that would be our suction irrigators. So on this last slide, here are a few examples. This one up here in the left corner, this is the Ellick evacuator. So you can see it's got a bulb here on the end. This is going to hook up to our cystoscope. So what we're going to do, and then the double glass barrel here, this is all glass. So we're going to pre-fill this with our irrigating solution that the surgeons had us get prior to the TURP starting. We're going to fill this whole thing up with saline. Then this end is going to connect to the cystoscope, and we're going to irrigate into the bladder. But as we let go of this, it's also going to suction all of that fluid back through and into here, along with any blood clots, particles, pieces of the prostate, things like that. Once that irrigation is all out, we will usually express this back out into our basin with a small filter or capture that will catch all of those prostate pieces. And we'll fill it back up and start the whole process over again until we get all of those pieces out. Okay, this bulb does come off too for easy dumping. Okay, then next to that, this is our asepto. As you can see, it looks like a turkey baster, and that's exactly what you'll hear it called sometimes. Down here is our suction irrigator. So as you can see, this one's going to be used for a laparoscopic procedure because it has this long nozzle. So what will happen is this end here is going to go off to our circulator. You can see this has a spike on it. So this will spike to a bag of either sterile water or normal saline, most commonly, to irrigate the cavity. And she's going to hook this end up to suction. So when the surgeon is using this, the blue button up here will shoot irrigation through here to irrigate the cavity. And then the red button he can push and it will suction all of that fluid back out. And down here is an example of our Toomey syringe, which we will also use for TURPs quite often. We'll fill it up. This adapter keeps it from squirting back up, and we can suction everything back in. Okay, guys, I know that was a lot of information. Please do look over and take note of those insights and tables. They provide a lot of extra information for you guys that would really benefit you. If you have any questions, please leave them here, and I will see you guys this afternoon.